position in the wellness centers are like idiopathic pulmonary fibrosis, subacute chronic hypersensitivity pneumonitis, and connective tissue related interstitial lung disease. So, what is idiopathic pulmonary fibrosis? It's an entity for which the pathogenesis is not known. It's commonly associated, seen in smokers, elderly males, 50 to 60 years of age, with the environmental exposures such as wood dust and sand and other, inorganic dust exposure. There may be a history of gastroesophageal reflux and remote viral infections. It's more common in males, seen in, as I said earlier, fifth to eighth decades of life. Dyspnea is the most prominent symptom in IPF, which is insidious and progressive. And they are associated with, it's associated with dry hacking cough, like which is non-productive. And then sometimes these coughing spells can result in desaturation and then syncope also. There are no other systemic symptoms. Clubbing may be seen in 50% of patients. And auscultation, typically we hear what we call as Velcro rails, bibasilar, end inspiratory, fine crackles. And then absence of signs of congestive heart failure. So, what are the patterns which you see on, then how do we go about investigating these cases like? Primarily, we go with the chest X-ray, followed by a HRCT of CT scan. So, HRCT of chest, where we find the thickened interlobular septal lines, the honeycombing, and then which are peripheral, which have a apicobasal gradient. And the most important aspect is like you see the pathology of it. There's heterogeneity, like we find foci of inflammation as well as fibrosis. And honeycombing is the hallmark of interstitial pulmonary fibrosis, idiopathic pulmonary fibrosis. If you find a peripheral, basal, honeycombing, reticulation, traction bronchiectasis, with temporal as well as spatial heterogeneity, that is diagnostic of idiopathic pulmonary fibrosis. And nowadays, HRCT of CT scan is sufficient enough to diagnose a case of IPF without resorting to a surgical lung biopsy. The second common entity which we see is a subacute or chronic hypersensitive pneumonitis, previously called as extrinsic allergic alveolitis. Generally, these patients present with a gradual onset of cough, dyspnea, fatigue, and weight loss. But there is no fever. There could be tachypnea and bibasilar dry rails, like in IPF. Chest radiographs are notable for diffuse linear and nodular radio densities, which are predominantly upper lobe. In the upper lobes, there could be sparing of the bases and there's volume loss. The HRCT of these patients show multiple centrilobular nodules 2 to 4 millimeters in diameter throughout the lung fields. Some areas of ground glass densities, especially in the lower lobes, can be seen. Next, please. So now we are able to see the ground glass in this HRCT, which is illustrated by the blue arrow on the left side, and the air trapping, which we see here. Next. Yeah. So, what are the key? So, summarizing the key investigations in interstitial lung disease would be a chest X-ray, which is essential, which predominantly shows mid and lower zone reticulation, reticulonodular pattern. Then it's followed by HRCT of the thorax, both inspiratory film as well as an expiratory film. Expiratory film, which brings out, the air trapping seen in hypersensitivity pneumonitis better. Then pulmonary function test with diffusing capacity, and we have a restrictive pattern on pulmonary function test. We also go on to do an ANA blot. That is, we have serology for connective tissue disorders. Bronchoscopy as such may not be essential, except that bronchoalveolar lavage sometimes can rule out infections. They may show predominant lymphocytosis as in hypersensitive pneumonitis, or sometimes predominant eosinophils in the lavage fluid, which we can see in eosinophilic lung disorders. Transbronchial biopsy has no role except in cases of sarcoidosis. The thoracoscopic or surgical lung biopsy is the gold standard to diagnose interstitial lung disease. Though we don't resort to this modality of investigation very often, because we have set patterns of which are seen on the HRCT of thorax, which are almost diagnostic of the disease entities which we commonly encounter. Other than the history of exposure, smoking history, the age, the sex, all these things, which we use to arrive at a particular diagnosis when we see a reticulonodular pattern which is predominantly basal on chest X-ray. So coming to the common connective tissue disorder related interstitial lung disease, rheumatoid arthritis stands first because it is the commonest connective tissue disorder which we encounter in the wellness center. Rheumatoid arthritis can precede interstitial lung disease, or it can present as an ILD, very rarely. It's more frequently seen in males. The male to female ratio is as high as 2:1. The onset of lung disease typically occurs in the 5th to 6th decade of life. Patients with rheumatoid arthritis have subclinical ILD on HRCT scans. So what are the risk factors in this particular age patients? It's the age, elderly age group, smoking, very high levels of rheumatoid factor in serum, and shared epitope of human leukocyte antigen HLA DRB1. Next. Again, pulmonary function tests which reveal a restrictive pattern on PFTs, where there is a reduced FVC and a normal FE1 FVC ratio, like with or without decreased diffusing capacity of the lung for carbon monoxide DLCO and hypoxemia. Airflow obstruction may coexist and be seen in patients with manifesting airway involvement. So, like rheumatoid arthritis can also present in other ways in lung, as part of lung disease, like respiratory bronchiolitis, can cause pleuritis, apart from interstitial lung disease, and rheumatoid nodules. And rheumatoid nodules in association with the pneumoconiosis, we know, which we commonly call as Kaplan syndrome. So, what are the HRCTs features in rheumatoid arthritis. Commonly, the UIP pattern is again seen in rheumatoid arthritis. That is what we see as a pleural-based honeycombing. The usual interstitial pneumonia, that is 40 to 60%, subpleural, basal predominant, reticular abnormality with honeycombing, traction bronchiectasis, but a relative absence of ground glass opacities. Ground glass opacities, which we see in hypersensitive pneumonitis, along with air trapping and central lobular nodules. Whereas in rheumatoid arthritis, ground glass opacities are absent. Other features are seen like traction bronchiectasis, reticular abnormality with honeycombing, subpleural location, and basal predominance. Next. Yeah, this is a this slide which shows some typical honeycombing. We also see a traction bronchiectasis, a little bit of ground glass opacities. Yeah, subpleural nature and basal predominance. Almost all the features typical of usual interstitial pneumonia are seen here. Yeah, next.
Yeah, so thank you, Dr. Srinivas Kumar, for taking us through.
From here onwards,
yeah,
Dr. Dadge would take on.
Yeah, thank you,
regarding the outcome of case. Yeah. One aspect, Dr. Dadge, before I close, I like one more aspect which we need to see in rheumatoid arthritis associated ILD is to look for signs of pulmonary hypertension.
Yes, sir.
That can be associated with RA-ILD, and then the drugs which we use, the methotrexate by themselves can cause
yes,
drug-induced interstitial lung disease.
Yes, sir.
So before I close, to summarize, the take-home message would be to look for the history of smoking, in an elderly male, history of exposure to birds, drugs which we commonly use like amiodarone, nitrofurantoin, bleomycin, and then methotrexate. Look for clubbing, look for signs of CTD, and look for the absence of signs of congestive heart failure, dry hacking cough, shortness of breath on exertion. You are at the diagnosis majority of the times, and over and above, we have when we have end inspiratory fine crackles bibasilar, which we call as Velcro rays.
Thank you, sir.
If you have any patient with such features, we are at the diagnosis of interstitial lung disease most often. Yeah, over to Dadge.
Yeah, thank you, Dr. Srinivas Kumar, for taking us through overview of interstitial lung disease and commonly seen interstitial lung disease in our wellness center. So we had this patient of elderly female with long-standing history of small joints and large joint pains with morning stiffness, and she was also coming with a history of dry cough and breathlessness. She was being treated by orthopedician with calcium, painkillers, and intermittent dosages of steroids. But in few months, her symptoms were worsening. So looking at her joint symptoms, first we thought of giving a differential diagnosis of connective tissue disorder like rheumatoid arthritis. So we ran few tests to look for the cause, and what we found is this patient had inflammatory arthritis in the form of raised CRP. The rheumatoid factor RA test was positive with high titers. The ANA was negative but the anti-CCP antibody, which is very specific for rheumatoid arthritis, showed a very high titer of more than 200. So looking at the clinical features of multiple joint pains, which are symmetrical in nature, involving multiple small joints, and positive CRP, ESR, along with positive anti-CCP and RA factor, as per the American Rheumatology College criteria, concluded that this patient has rheumatoid arthritis. And when we examine the patient has bilateral basal fine creps. And this was a CT scan showing subchondral reticular abnormalities, which are seen clearly here. So this is the patient of rheumatoid arthritis related interstitial lung disease. So this is a rheumatoid lung presenting as a interstitial lung disease. And this was the report of HRCT thorax with a subchondral, interlobular and intralobular septal thickening, which was associated with traction and predominantly in lower lobe as shown in the picture. So this confirmed our suspicion that this patient has rheumatoid arthritis related interstitial lung disease. And we started this patient on methotrexate, which he never received previously, and with some steroids, which forms the management of such cases. We ran methotrexate from 7.5 milligram once a week to 10 milligrams now, once a week, with steroids for 2 months. And we had just a follow-up last week of the patient, which showed that there is a complete resolution of her joint symptoms and her cough and breathlessness has reduced by more than 90%. We also did pulmonary function test of this patient, which showed very mild restrictive disease, but the diffusing capacity was preserved. We picked up this case quite early. Maybe that is the reason why the diffusing capacity was not that affected. We have to keep in mind in such patients that they can get drug-induced pneumonitis because of the methotrexate, but it is quite rare. We can also use mycophenolate or other immunosuppressive agents like azathioprine. Other than drug treatment, we have to emphasize on smoking cessation if these patients are smoking, and if there is a history of gastroesophageal reflux, treat with them with PPIs. Supplemental oxygen may be required in late patients who present with severe hypoxemia, and we never forget to vaccinate them against yearly influenza vaccine and once a pneumococcal vaccine during the course of their illness. So this is a brief management of how we manage rheumatoid arthritis related interstitial lung disease. This may be one of the patients that you may see in your wellness centers. Usually the males are the one who get it more often, but our patient was a female, and patient had very high titers of rheumatoid arthritis related antibodies and antigens, and this is the reason why she had rheumatoid arthritis related interstitial lung disease. But majority of the patients will have subclinical disease. They may not be symptomatic, but you can look for it doing HRCT scan. So prognosis is not so good once the interstitial lung disease is there in rheumatoid arthritis. It contributes to death in around 6 and 10% of the males patients. The risk factors for mortality, advanced age, male sex, and UIP pattern on the HRCT biopsy. If the patient's diffusing capacity is affected, that can also contribute to increased mortality. But overall, the rheumatoid arthritis ILD has a better prognosis. The mean survival as per the statistics is 2.6 years from the time of the diagnosis. And if the patient has only rheumatoid arthritis without lung involvement, just see the difference in the survival. So the onset of interstitial lung disease in rheumatoid arthritis, these patients are prone for early death. So we need to identify them earlier and treat them aggressively. So there was a
Yeah.
discussion on traction bronchiolactasis, and this is one scan which shows that this is the bronchus which is going towards periphery, but as it goes towards the periphery, it should taper normally, but this is not tapering. But because of the fibrosis traction on the both sides, it dilates and gives rise to this appearance of traction bronchiolactasis. So the clinical pearl of the case is any patient of chronic dry cough or dyspnea with a bibasal velcro graft, think about interstitial lung disease. And if this patient of rheumatoid arthritis or SLE or other connective tissue diseases come to you with chronic cough dyspnea, think about connective tissue related interstitial lung disease. So if there are any questions, we have only 1 minute left for the free session. They can ask. And I thank you, Dr. Mysore Srinivas, for taking out time from his busy schedule. Dr. Subbalakshmi wants to ask question. Yes, Dr.
So
Subbalakshmi.
one question regarding the prognosis of rheumatoid arthritis.
Yes.
Is ILD and rheumatoid arthritis without lung involvement. You had mentioned that rheumatoid arthritis without lung involvement is about 9.9 years. Could you just clarify that, sir? I'm not able to understand that 9.9 years if they don't have lung involvement.
So it's very simple to understand. This is if it is restricted only to the joints, then they live longer. But if you have lung involvement, because of the involvement of one more organ in the rheumatoid arthritis and associated morbidity because of hypoxemia, respiratory failure, these patients live lesser than the patients who have lung involvement. So it is about how many organs are involved in rheumatoid arthritis, and that decides the mortality and morbidity.
So before we close, I think we should harp